North Africa and has some experience working in South Africa. She'll be speaking about HIV late presentation. So please, everyone, welcome Dr. Burgess.
Hello, thank you so much. Thanks for inviting me and thank you for the introduction. I hope you find this useful. This is a project. I'm based in Bristol in the UK, and this is a project that we've done recently looking at our patient population that have presented late with HIV, which I've completed with some other resident doctors, supervised by Dr. Megan Jenkins, who's an infectious diseases consultant. So, because I'm based here in the UK, so just in our situation here is that we have around 6,000 new HIV diagnoses in England. That was the figures from 2023. That's quite I'll just move this. That's quite an increase from 2022, a 51% increase. And a lot of that is probably related to what happened during the pandemic. But half of these diagnoses aren't new diagnoses. They're actually previously diagnosed abroad. That's important to recognise, but don't actually reflect transmission in England. And it's those diagnosed for the first time in England that we'll be concentrating on in this project. So I'm trying to work out where best to put you so that you can see the graphs. I'll put you in the middle. So, oh, there you go, that's better. So the number of HIV diagnoses first made in England is also increased. And what's changing in the demographic is that nearly half of those are among people exposed through sex between men and women. So looking at the graph here, that the sort of teal colour, greeny colour is the number of diagnoses with the route of exposure between sex between men, and the orange and the blue are route of exposure is sex between men and women, and the demographic is changing, and so nearly half of people are exposed through sex between men and women. The diagnosis term first made in England is really just so we can look at transmission rates and transmission within the UK. So this is a project looking particularly at HIV late diagnosis, and the definition of a late HIV diagnosis in the UK is a CD4 count below 350 cells within 91 days of diagnosis. And that is increasing within the UK, but essentially the proportion of those diagnosed late has remained fairly stable, and that's around 40% of people. The highest proportion of those diagnosed late are people who are aged over 50, men exposed through sex with women, people of Black ethnicity, and those of Asian ethnicity. And these are all figures from released in October of this year. So the impact of a diagnosis late is that those first diagnosed late in England are around 10 times more likely to die within a year of their diagnosis compared to those who were diagnosed promptly. I'll share these slides. There's a lot of information on them, and this is the latest UK data from 2024. So those diagnosed late, the highest mortality rates are aged over 65, and although those over 50, and those exposed to injecting drug use or living outside of London. So actions, I may just need to take a drink of water. Sorry, I've been working all day and I'm not a bit, I might have to go and get something. It's not nearby. Give me a second.
No problem.
Just to add, if there's any questions throughout the talk, just pop your questions in the chat and we can come to them at the end.
Sorry about that. I realised I've been talking all day and suddenly I'm getting a bit dry. So the HIV summary for reducing HIV transmission in England, with the aims that in 2025 we should reduce HIV transmissions by 80% and by 2030 to end all new HIV transmissions. And as part of that, late HIV diagnosis should be investigated as a serious incident. Oops. So that reviews have been guided by BEVA standards of care, and they've produced this late diagnosis review protocol, which is available at this link, and that was the basis for this project. So the aim was to understand the reasons for late diagnoses and identify where missed opportunities for testing may have occurred, and then to create some targeted interventions to increase testing when indicated. And do stop me because there's quite a lot of data here and I may need to skip over a few slides. So we looked at all late diagnosis of HIV in adult patients who were referred to our central services in Bristol between January 2021 and May 2024. Patients all had a Bristol-based address, allowing access to medical records through Connecting Care, which is our records system, particularly in GP practices. All patients needed to be resident in the UK for at least 2 months and no evidence of recently acquired HIV. So we looked at various different sources of information, and then we are now looking at various interventions as the result of this study. So we identified 52 patients who had been diagnosed with HIV with a CD4 count less than 350 between January 2021 and May 2024. 10 of those patients didn't fulfill the inclusion criteria because they were either not in our area, previously known positive, or had avidity testing indicating that actually this is a very early HIV infection rather than a late one. I'll mention that a little bit more on the next slide. So we had 42 patients included for further analysis. So just in terms of the natural history of HIV, which I'm sure you're all aware of, that in acute HIV syndrome, you can have a dip in your CD4, and that's not an indication of late infection. And you can test for that with avidity testing, looking at the strength of the immune response to HIV. And if the immune response is quite low, and that's what this index is, then that indicates you're actually in an acute phase of HIV rather than presenting late. So that patient was excluded. So the results of our project, most of our patients were white British men, and then we had patients who were also Black and Black African and from other European and Asian countries. 10 of our patients had a partner that they knew was HIV positive, and 19 of the 42 patients identified as men who have sex with men. Looking at patient demographics, most of our patients, so 20 of the patients were from the UK, and then 6 patients were from high prevalence countries, of which 2 were from Kenya, 1 from South Africa, and 3 from Zimbabwe. This is to do with other patient characteristics. So 9 of our patients were documented as having unprotected sexual contact. 5 patients were documented as having multiple sexual partners, and 3 had reported previous or current intravenous drug use. In terms of the location of the diagnosis, 16 of the 40 patients were actually diagnosed in general practice, 13 as hospital inpatients, and then the others were in sexual health services, hospital outpatients, and 1 patient was diagnosed antenatally. About half the patients were under 40 and about half were over 40, sort of reflecting the national data that some of these patients who were late diagnosis in particular are in the older age range. The location of diagnosis by age is shown here, and the light blue shows the 8 patients who were younger and they were diagnosed in sexual health services. And then in general practice, hospital inpatient and outpatient, it was a range of ages. there was no correlation between the age of the patient diagnosis and their CD4 count. We looked to see if there was any particular signal between those who were UK patients versus those who were from high prevalence countries, and there was there were sort of lower CD4 counts, but there was only very small numbers in those who were from high prevalence countries. And then again, looking by ethnicity, there was a very low CD4 count, in particular with those from Black, British, Caribbean or Caribbean heritage. And in terms of the CD4 count by place of diagnosis, unsurprisingly, those who were diagnosed as inpatients had lower CD4 counts than those diagnosed in the community and sexual health clinics. And in Bristol, we are now testing all patients that attend A&E who have not had an HIV test in the last year. They are all now being tested for HIV and Hep B and hepatitis C, unless they, so we look to see, because this predates that introduction, whether this would make a big impact. And around 25 of the patients in this order were never admitted. So it is still important to be aware of testing for HIV in the community, and that just this A&E testing will not pick up all the late diagnosis. So a missed opportunity for testing was defined as a delay in diagnosis of at least 1 month from presentation to a health service with a clinical indicator condition for testing for HIV. And that's based, our clinical indicators for testing are based on the BEVA, so that's the British HIV Association and the British Infection Association Adult HIV Testing Guideline, which is from 2020. And there are two main categories. One is conditions that would be age defining in an individual living with HIV, and the other category is non-age defining conditions associated with an undiagnosed HIV seroprevalence over 1 in 1,000. So these are listed on the next 2 slides, and I think you'll be familiar with a lot of these conditions that would be age defining in an individual living with HIV, and I'll share these slides with you as well. And these are the non-age defining, but are conditions but associated with a seroprevalence more than 1 in 1,000. So these are all indications for HIV testing. So looking at the records of these patients, 60% or 25 patients had presented to a UK healthcare service with one of these conditions at least a month before their diagnosis, with a potential delay in diagnosis from 1 month to 70 months. And on average, there was a 15-month delay in diagnosis. This is, can't move that, but this is the location that they first presented with a clinical indicator condition with the potential delay in diagnosis. So the light blue and blue are around 1 to 3 or 3 to 6 months. Prior to their diagnosis, they presented with an indicator condition, but the sort of gold and orange and red, they're sort of increasing duration of delay between presentation, so up to 70 months prior to their diagnosis. Potentially they could have, they would have had an indication for an HIV test. And then this is looking at the location that they first presented and then their ultimate CD4 count. And 7 of the patients who presented to GP practice with a clinical indicator condition ultimately had a CD4 count less than 100. And so that was really somewhere we need to target. So this was just, it's not a statistically significant correlation, but within the, this is looking at CD4 count of diagnosis against the potential delay in diagnosis. And in the gold box, those who had a delay of less than 5 months and a CD4 count, which was over around 200. But in the red box, there was delay in diagnosis of at least 5 months or longer. And you can see that the CD4 counts are almost all under 150. And then these 3 patients who are now highlighted, unfortunately, they had significant delays and unfortunately died of HIV-related complications. This is the location that the patients first presented and the indicator condition that they had at the time. So in the sort of dark blue, there's herpes zoster or shingles, and that was seen 5 patients presented to their GP, but also emergency department and the eye hospital. And so none of these patients had HIV tests, but there was a variety of indicator conditions. So pneumonia was pretty common at the general practice and was also seen in respiratory. Chronic diarrhea was seen in, where was it gone? Yes, it's in blue as well, with in the GP practice. Esophageal candidiasis, new diagnosis of seborrheic dermatitis, unexplained lymphadenopathy, unexplained oral candidiasis, and unexplained fever, which you'll all be familiar with. This is just looking a little bit more detail about leukocytopenia or thrombocytopenia, and just delving a little bit more deeply. And overall, 9 patients at any point had a missed opportunity for testing, as they had either of one or either of these conditions, and didn't have an HIV test. This is looking a little bit more detail in those patients that died, and all the times they presented to a hospital or healthcare facility with a clinical indicator condition, and did not have an HIV test. Unfortunately, the delays were quite significant, with a 13-month delay for one patient, 21 months and 25 months, respectively, and very low CD4 counts, 29, 32, and 14. So these are all opportunities that essentially were missed for testing and may have made a difference to the outcome. This was just a case because this is our one patient that was diagnosed antenatally at a late stage. And her missed opportunity was that she was previously known to be HIV negative in a previous pregnancy, but had CIN3 on a smear, which is actually indication for HIV testing, although it's not routinely done, in November 2022, and subsequently became pregnant and was diagnosed antenatally in March. So it would have been a lot simpler if she had been tested in November prior to her pregnancy, and she had avidity testing which should show that this was an established infection of at least 4 months, and ultimately she had a cesarean section. So this is something we were going to discuss with our gynecology colleagues about potential for HIV testing for this indication. So this was a retrospective study. I'm not sure what things are like where you are, but we have a totally different system for sexual health data, so we're not able to access those records based on the demographic information that I have from the hospital data. Some patients may have declined for the hospital to have access to the GP records. They may have presented to different hospitals outside our area. It is also possible they were offered HIV tests but refused, and this is often not documented. And also there is a possibility people were presenting with indicator conditions, but they were not recorded or not recognised, and we wouldn't know about those cases. So we're doing a lot of different education events. So this has been presented regionally at our Southwest HIV meeting, and also at our local HIV meeting and infection and research meetings. At a GP education day. So we're also meeting with different departments to talk about specific cases of missed opportunities. A few of the patients actually had clinical indicator conditions on their radiology reports, such as pneumonia. A couple had generalized lymphadenopathy, and we're planning to meet with the radiology department to see if they can support clinicians to request HIV tests. And also the reason I was looking into the hematology reports in a bit more detail is we're wondering whether we could support GPs to test, and also hospital clinicians in the right circumstances. And locally, we're going to be reviewing our late diagnoses a bit more regularly at a 6-month point, and report them to our morbidity and mortality meeting, and using this late diagnosis review protocol that's been recommended nationally. And next steps are sort of potentially thinking around duty of candour and any evidence of harm that these patients came to through a misdiagnosis. That was a little bit of a whistle stop because I wasn't sure if I'd get through it all in time. And I hope it is sort of, I know the situation is going to be quite different where you are, but this is what we're doing in Bristol. And I just hope that there is some sort of useful points and things that you can apply.
Thank you so much, Dr. Burgess. I'm Stephen Bitok. It has been an informative session, and I would like to, I bet all of us would agree that has been. I would like to welcome anyone anyone who has a question. There are no. If no question,
anyone who has a question, also write them in the chat. You can unmute or write them in the chat, and we can read them out for you.
Yeah. Any questions? Once more.
Somebody's very busy there. That I can see.
Cooking chapatis, maybe. So there's one question. I'd be interested to hear your thoughts on the new routine testing of all patients for bloodborne viruses on admission to hospital at both a patient and systems level. I haven't yet seen a positive screen, but appreciate the importance of early detection.
This is the new sort of blanket testing. Well, it's just been rolled out. I think it started on the sort of 9th of October. So it is something that we're monitoring to see how many new positive results we get. So far, I think all the positives are actually being patients who have defaulted or are not adherent to treatment, or known positives. But it's only been going for a couple of months, but we will be reviewing all those cases.
Thank you, Ben, for that question.
Can I just ask a quick question, Alison?
Amy,
hi. I thought your talk was really interesting, and I think we do miss the opportunity to pick up HIV positive patients if we don't implement blanket testing. But as a lab person, I was just wondering, how did you go about getting that funded?
I don't know. Adele is actually leading on it on a sort of national level, and she was going to drop in, but I don't think she's here right now. But it's based. I wasn't going to go into a lot of detail, but it's based on an initiative called Fast Track Cities, which doesn't have any actual funding, but sort of attracts funding, and it's based on as a threshold of prevalence. So it's already been rolled out in London, Birmingham, and some other major cities, and then Bristol is now at the threshold where it feels that it is economically viable. You're in Gloucester, aren't you, Amy? So you're below the threshold, so you wouldn't qualify, but it attracts its own funding. And so all those HIV tests are funded separately from the other HIV testing within the hospital.
And does that get shared out to community colleagues and then have to pick these patients up?
No. What's happening is there's a sort of standard operating procedure for all these positives, and they're actually all going through our HIV specialist nurses.
Okay.
Who are already quite busy.
Yeah, I mean, it's great that we identify these patients, but then you've got to provide adequate ongoing care for them. And I think that sometimes there's one initiative in one hand and then it falls down in another area. But it's a really useful conversation to be having, isn't it?
Yes, because we have got a robust system in place for any HIV positive patients diagnosed within the hospital. So it's going through the same system. There is funding for the testing, but I'm not sure there's extra funding for the nursing time. But we're expecting quite low numbers of positives, and so far I don't think we've had any new diagnoses. They've all been known, or they were aware that they were positive, but maybe didn't disclose, or maybe they were accidentally retested.
Thank you.
We have one more question from Madeline. You mentioned outside London is a RF. Is that simply due to routine testing in London, or are there any other factors involved?
It's in they're doing blanket. They're doing opt-out testing in London. Was that you? What you talking about?
Madeline, do you mind clarifying?
Yeah, that was what I was thinking. Absolutely.
Yeah, so London, they're doing opt-out testing in A&E. So I think if it's the same as we are doing, if you haven't had an HIV test in the previous year, it's opt-out testing. So they have I've now just forgot the name, but they have a sort of a package of tests that they do for new admissions, and now it includes HIV, unless the patient opts out. And that's been running in London at least 3 or 4 years, and we've just started here in Bristol. It's not something I've been hugely involved with, but I do sort of know about it.
So I guess my question was really, sorry about the chat background, whether it is simply the blanket testing that seems to be altering the prevalence as a risk factor, or presence outside of London as a risk factor, or if we have any idea why people outside of London are more likely to be diagnosed at a later stage, if there's any other factors.
Oh, I see. Well, I think those figures have been like that predating the opt-out testing, even in London, and it is probably due to access to care and maybe awareness of diagnosis, being in perhaps a demographic that doesn't recognise risk. So yes, it's actually multifactorial why those outside of London are being diagnosed late. And I think that sort of risk predates the fact that London are doing opt-out testing. But it hope that would add to it now.
Okay, so hope there are no other questions. Thank you so much, Dr. Burgess. So moving on to the other team in Nanyuki, we would love to introduce Anne, Rachel, Cecilia, Patrick, and Elvis, who are working at the Comprehensive Care Center in Nanyuki, Kenya, and are doing an amazing work. It will be a mix of videos and speakers. Kindly let's welcome them. Anne, to you.
Hello.
Hi, welcome.
Hello, my name is Anne.
Hi, Anne. We're gonna go ahead and play the video.
Okay.
Right? Yeah.
My name is Anne. Welcome to our room. I'm a HTS counselor. HTS means HIV testing and other services. And also we have other rooms for service delivery points. We have one in MCH where we do the testing for pregnant and breastfeeding mothers. And also we have one in inpatient and in the maternage. And also we have one in special clinics. Okay, welcome so much. In our testing room, we have pre-test counseling. I'm going to take you through whatever we do in pre-test counseling. I'm going to talk about 5 C's. We have consent, confidentiality, counseling, correct results, and connection. And also in pre-test counseling, we talk about HIV information and also prevention to our clients, and how many the time we are going to take during the counseling. Okay, after pre-test counseling, we go to the testing part. That is where we have different types of testing kits. We have determine, we have fast response. We start with the determine. That is the test that we do screening for HIV. If it turns negative, we don't go to the second test kit. That is where we stop there. We teach the client how to prevent themselves for HIV, and we give them TCAs for retesting. And also we link them to other services that they need during that day. When it turns positive, we go to the second test kit. That is the first response. And it turns positive, it is confirmed that that person is HIV positive. And then we go to post-counseling. That is where after we do the post-counseling for the positive client, we escort them to the CCC. That is Comprehensive Care Center. That is where they are linked for treatment and care. And they are also done there, also the adherence counseling. Thank you so much.
I am Rachel, nurse working here at the CCC. This is CCC waiting bay, where our clients wait as we start off. We start serving them on first come, first serve basis. Then from there, once we are here, this is where we take their vitals, we take their blood pressure, their pulse rate, and weight. Once we have done with that, then they are confirmed their attendance at this desk. Then from there, we come to the triage room, where we do triage via EMR, so that the clinician is able to see the client on their system. We verify with whatever has been taken at the vital signs. Then from there, we come to the consultation room, where our clients are now going to be seen by the clinician. At the clinician place, the clinician will go through the EMR and confirm the date. From there, if the client is to be referred to, for maybe client is due for viral load, he will refer the patient for viral load. Or if the client is for screening, cancer screening, will be referred for cancer screening. If the client has issues with the adherence, or maybe is lost to follow up, then the clinician will refer that patient to the adherence counselor. Or if the client is for return to care package, they will also refer to the social work, which I'm going to show you right away. This is where our clients will be seen by the adherence counselor if they have issues. If they have been referred here from the clinician place, this is where the client will be seen by the adherence counselor. And then the adherence counselor will sit down with the client and discuss what could be the reasons why we have the viral load being high, or what are the reasons for missing appointments. And then once they identify the root causes of why the viral load is high, or why she's not attending to appointments, then she'll be able to establish that we need to have an MDT as a team and discuss this client. Once we discuss this client is when we shall now plan for either home visit, so that we can see how the client is faring back at home. Are there any obstacles to treatment adherence? or is the client keeping our medication well? At the MDT, we shall also discuss if we need to now have the client take our medication while being observed by the next person. That is when we arrive at home, we will discuss with the client if we can have someone who will help her in taking their medication in order to improve their appearance. From there, this is the linkage desk where we have the social work who is going to maybe talk to clients who are not coming for their appointments. They will try to establish what the problem was. In this room, this is where we do screening. This is where we do screening for our female clients in the reproductive age. From age 20, as long as the client is sexually active, from 20 years to 49 years, we do the FIA. Those who are above 49, or rather those who are not having their menses, we do pap smear. In this room, we also screen for other STIs and advise appropriately, or we refer them back to the clinician. Once we get an STI, we refer the client back to the clinician for treatment. In this room, we also discuss about their family planning. Those who need family planning services, they are also supposed to get them in this room. So from the clinician room, our clients will either come to cervical cancer screening or adherence counseling, or at the social work desk. All client will be referred to laboratory for maybe field. Once they are done with all that rotation, then the last place to go is the pharmacy, which is within our building, where the client will be given our medication and then they go home.
Right, so those were Rachel and Anne, who are also on the call. So I'm sure we'll be able to maybe have a nice discussion after. So now it is Cecilia, who is a clinical officer in the comprehensive care clinic in Nanyuki, and she'll be talking about the standard package of care for people living with HIV. Cecilia, are you here?
Hi. Yeah, I'm Cecilia. I'll be talking about the standard package of care, which we have 8 components in it. And the first one is about the antiretroviral therapy. Yeah, after the testing of the patient, whenever the patient is positive, regardless of the CD4, whose stage, age, pregnancy are started on heart. But we delay the patients with meningitis for 5 weeks and also tuberculosis for 2 weeks. Then we talk to them about positive health, dignity and prevention, GBV, IPV, and health education. So for those patients who are positive, we tell them about the importance of disclosure of HIV status, treatment adherence, and also we educate them on the drugs. So we also do the screening and prevention of the OIs. So for this, we give Septrin, and not all patients are given Septrin currently. So for those who are given Septrin are HIV-exposed infants, HIV infected less than 15 years, also those above 15 years living in malaria endemic zones, presenting with WHO stage 3 and 4, suspected treatment failure, that is those patients with high viral loads, and also all pregnant and breastfeeding women. Then we have productive health services, that is screening for sexually transmitted diseases and pregnancy at every clinic visit. And also we do cancer screening for our patient between 25 to 49 women, age women, because it's a common one in these women's. Also, we do screening and management of the NCDs, that is hypertension and diabetic. So whenever you are taking vitals for the blood pressure, we check their BPs. If they are high, we do manage, or we book for MOPC for senior review. Also, we do mental health screen and management. For this, we dealing with anxiety and depression first. So for anxiety, we use GAD-7. Those are 7 questions that we ask the client. For the depression, we have 9 questions that we ask. Also, we assess alcohol that we use. For adults, we use CAGE, and for adolescents, we use CRAFT. They are the questions that we use. So we also do nutrition services to assess their nutrition assessment. So we do height, and also we do their weight, so that we can do the BMI to see if they have any malnutrition disorder. Then we have prevention of other infections. That is, we do vaccinate our clients according to the guidelines. Thank you.
Right, thank you ever so much, Cecilia. We're going to move on to some audit and quality improvement that they're also doing in the CCC. That will be presented by Patrick, who is a data analyst. We're going to start with a small video again, where he's going through some graphs, and then he'll explain a bit further after that.
So I'm Patrick, Data Manager Officer at Nanyuki Teaching and Referral Hospital. So I'm presenting you a dashboard that we do track our data on every monthly basis. So starting is our target. We always have annual target, starting from testing, positives, care and treatment, TB and HIV, PMTCT, prevention, and so on. So we always do our work through those targets. So coming to other dashboards, we track our retention into care through this indicator. One is we track how many people we reported previous month, how many people that we have reported new client, return to care, and all those losses and gains, we always track them in care. An instance of the number that we reported last month, which was August, we reported 2099 versus whatever we reported September 2104. So we want to account for the difference and see where each and every client went in case of any client that missed in our data. So going onwards to tracking the defaulters, so we always track how many people we have booked versus how many clients that have come. Then the number that didn't come, we give them to CHV for tracing. So moving onward to CQIs, we always have CQI meetings. These are continuous quality improving meetings, whereby we get the variance or the gaps that we always have in the clinic. We track them on every monthly basis. For a new recent, this was a barrier that we identified that 10 of our clients that was children living with HIV were not suppressed. So we wanted to give ourselves a timeline up to April 2024 and make sure that these clients have suppressed. So we tracked them on this month, October, November, up to August of 2024. And by August, all our clients had already suppressed. So this was our best practice that we did in our facility by identifying the barriers and going back to community to their home visit and making sure that these clients have suppressed. So that was our best practice that was presented in our regional meetings that we meet with other facilities and in the other counties and discuss their best practice. As we had, we were saying, we always do a retention we also do retention accounting for 6 months and 1 year. So at every month. So these are clients that started on ART 6 months. Then these are clients that started on ART 1 year back. So for 1 year retention, we were doing at 92%. And for 6 months also, we were doing at 92%. So 92% is way below our target, of which we are saying that our target for retention is 95%. So going back to viral load, we are supposed to have a 95% suppression of our clients. So we track our viral load upticks. So the viral load is a test that we do to make sure that our clients are suppressed and to know how they have suppressed. So as you can see, in September, we had 98%. That's attaining our target of 95% suppression. So these were given by 72% of viral load uptake. So on that point, we had issue on doing those viral load tests. That's why we were doing at 72%. You can see other previous month, we were doing at 95, 90, 93. So the problem was inevitable. We couldn't have do anything about it. So that was it. So
So I'll now let Patrick talk a bit further.
Yes, good evening. So thank you to the area presenter. They did a good job. So this is map of Kenya. We enjoy the sun at the equator. So for those that have never visited, so you can come and enjoy the sun. Okay. So yeah, this is our hospital statistic. We were to present a statistic on how we distribute or on how our patients are distributed. Currently, we are serving 21,109 clients, of whom 33% are male and 67 are female, and 88% of them are adult of above 25 years. For children, we serve 2%, that is children of 0 to 9 years, and adolescent 10 to 19, they are 5%. And for youth 20 to 24, we are serving 110 client, giving us 5%. Okay, so as the area presenters, Rachel and Cecilia has said, so a lot of services we offer, we track them, and we use electronic medical record known as Kenya EMR. So this is a system that we started back in 2021, and we were doing bad on cancer screening and viral load uptake. So we wanted to use this system to better those indicators. So the system helped us to flag out those viral load, those clients that were due for viral load, which when using paper, we couldn't have done it. So the system also helped us to highlight those clients that were due for cancer screening. Unlike when we were using papers, we couldn't have noticed them easily. So the EMR also helped us to do DQAs and identify those gaps with ease. So the graph you can see there is an illustration of how these indicators moved with an upward trajectory. Starting with cancer screening from 2019, we were able to improve from 34% to 82%. Then on viral load uptake, we were able to improve from 83% to 98%. So next. So this is also another best practice that we also presented it in regional meetings that we usually have. So we wanted to see the quality of care the EMR was giving us. And we were tracking some of indicators that Cecilia maybe had talked about on her presentation of standard care of package. So we wanted to see how many non-communicable disease patients we were able to track or to identify using EMR. So we moved from 12 to 17 to 178 while using EMR. So we were also able to give our client more TCA, which we call MMND, or month drug dispensing. So which we moved from 48% to 87%. So the EMR also assisted us in improving cancer screening by 5%. Also, it helped us to improve TPT, that is TB preventive therapy, from 46% to 88%. So as earlier Cecilia had talked about that, this is a component that we need to do and to make sure that all our clients have been given TB preventive therapy. So the EMR also assisted us in screening for TB. So we were able to move from 95% screening rate to 97%. So for viral load uptake, EMR also assisted us to move from 32% to 87%. So the EMR also came up with a module, we call it Lab Manifest. So this is a module that pull the result direct from the national lab into our systems. Unlike before, we used to key in those lab result manually. So by the time the result are getting in our system, it's already 1 month or 2 months rate. Next. Okay, so in our day-to-day activity at Nanyuki Hospital, we usually have many activities. One of them is Hay graduation. Especially this, we do it on annual basis. So we call it as one of our achievement, whereby, for instance, this year we were able to graduate 55 children who were hay exposed. So that was 29 of November. That's when we did our annual hay graduation. So it's a success, helping those children to go through that process and come out negative. So we also have another achievement or a success story. We call it Operation 000 Crab. This is a crab for adolescent, and I guess it will be talked later in length. Then we have community ERT groups and men ERT club. So these are groups that help us to dispense drugs, maybe to community level. For men ERT club, they join together, they come for their medication to clinic by sending maybe one of their peer. We also have active MDTs, data reviews, and CQI meetings. These are meetings that we do them on monthly basis, and they help us to track the gaps and act accordingly. So by tracking them, we use that data for decision making. So suppression, we are doing at 97%. Maybe I heard from UK, they concentrate more on CD4, but for us, we do gauge ourselves by viral load. So for us to know that we are giving quality services, we do viral load to a patient, and we are doing at 97%. That means 97% of our clients are virally suppressed, they are LDL, and hence they cannot transmit viruses to their spouses. So we also do CQI projects, like the area we saw on the video. That was a CQI of the 10 children who had high viral loads, and we were able to track them to until they suppressed. So we have various projects on CQI that are running. I guess if there's okay, thank you.
Thank you so much, Patrick. Asante sana. That was amazing. We're now gonna go over to our last speaker, who is Elvis, the HIV youth champion working in the comprehensive care clinic. And he's gonna talk a bit further about the Operation 000 that Patrick has mentioned, which is a very successful way for social inclusion. Right, the floor is yours, Elvis.
Hi, everyone. Thank you, Charlene, and thank you to the previous speakers. They have done a really good job. My name is Elvis Wangari, an adolescent, a proud member of the OTZ Club, and a proud young person living with HIV. So I'm part of the success stories that go on in the CCC, as I was born with HIV and I'm living with HIV. So OTZ is part of the best practices that we have had in the CCC, in the Nanyuki CCC, as Patrick has talked about. And OTZ is known as Operation 000. It's a club for young people living with HIV between the ages of 10 to 19 years. And in the OTZ, we actually talk about the 3 zeros. The 3 zeros include 0 missed appointments, 0 missed drugs, and 0 viral load. So this is a thing that we have come to understand that in the clinical field, we concentrate more on no missing appointment, no missing drugs, no viral load. So which means if you don't miss your appointment, you won't miss your drugs. And when you don't miss your drugs, your viral load will be suppressed. So those are the 3 zeros. But as the OTZ club, we actually decided that those are not enough. We have to add more, so that let's say you can call it 10 or 100 zeros. But here we actually deal with we said that we'll concentrate more on these ones, the 0 EMTCT, which means as young people, we don't want to transmit HIV to our sexual partners and the young generation that will be coming from us, so our children. So we don't want to transmit to them. We want 0 stigma, we want 0 deaths, we want 0 new infections. So we don't want to infect our partners, our sexual partners, or reinfect our sexual partners. We are saying we want 0 missed schools. We want non-linkage to care. We want everybody to be linked to care. If everybody is found positive, if young people are found positive, we don't want to lose anybody who is not being linked to care. We also have decided to talk about 0 unprotected sex, so that we don't infect the partners. So our motto here is heroes for zeros and zeros for heroes. So it takes a hero to be a 0 and a 0 to be a hero. That's our motto. So in the clinical cascade, or the clinical targets that are given by the units, we talk about the identification. The first 95 as identification, the second 95 as retention, and the third 95 as suppression. So for us as OTZ, we concentrate more on the three targets, but we also have an extra target for us. So for the first 95, what we actually do is sensitize their peers on the need to know their status. So most of the young people don't know their status. So we sensitize our peers to know their status. We also escort the HTS to service points. So by this, I mean when HTS, like for example, Anne, the first speaker, when she goes for testing, she might include us to go and actually talk about HIV to the young people. And also the young people want familiar faces. So they don't want to see maybe an older person going to test them, which will make them like not feel free or comfortable with that person. So they want a familiar face to this face of mine. Yes. So we also get their sexual contact, which means those who are tested, we do something we call PNS, which is Partner Notification Service, where we know these days one partner has many partners. So we help them, we help those other partners to know their status. So that's the first 95. The second 95, we talk about escort and linkage to care. So for those who are tested, who test positive, we help in linkage to treatment. We also share our own stories to make those who are linked to care, the newly enrolled, to identify that they are not alone. We are a group of young people who are willing to live and share our experiences with them. We also help in optimization of treatment. By this, I mean Patrick and Cecilia talked about MDTs. So we participate in MDT where we discuss cases where we have fellow peers failing in treatment. So we actually help give suggestion in helping optimize their treatment. We also do differentiated care. So OTZ is part of the differentiated care service delivery that we do here. So this is by giving adolescent a different day, giving them a different time to come. So this is part of the second 95. We also do PHDP. I think Cecilia has talked about positive health, dignity, and prevention. So I want to talk about that. So we'll go to the third 95. So the third 95 is about suppression. So you can see OTZ Club is under suppression because we deal more on viral load. We've said zero viral load. So OTZ is part of the third 95. We also do peer-to-peer support in adherence and care and retention. By this we mean for those young people who are failing in treatment, we do adherence counseling to them. We try to find out what might be the issue for them not to adhere to their treatment. Then our own target, the third 95, we not only talk about the care and treatment in the hospital, we also talk about there's more to the world than the CCC. So we also talk about their education. We encourage them to go to school, to finish school. That's why we had added a zero miss school. We also we also guide them on their careers. We also bring on board career advisors who helps them to decide on their careers. We also do on relationships. We know young people these days are afraid to disclose their status. So we talk about the challenges within their relationship and how they can maneuver with those relationships and on how they can use disclosure as part of the treatment. So next. That image actually represents what the young people are saying in the OTZ. So we say LDL ngao yetu, which means LDL less than detectable levels is our shield. So these days we say U is equals to undetectable is equals to untransmittable. So that's one of the things they talk about. We say 100% suppression is achievable and many more. So next slide. So we saw that OTZ, and let me put this out there, OTZ is not a one-man show. OTZ is a team effort. So Team CCC Team Nanyuki CCC decided to sit down, form this OTZ, and empower the young people to adhere to their medication, and also succeed in their careers, in their line of work. So with that, we decided and sat down and decided to write a best practice and show Kenya and the world that this is something that can be achieved anywhere. And this is an abstract that I presented in the third, it was the third South Rift Valley International HIV Prevention Care Treatment Best Practice Forum that was held this year in July in Bomet County. So next slide. So the background of the study was how OTZ helped Nanyuki Teaching and Referral Hospital improve suppression and retention from 85% to 95%. So next slide. So NTRH identified that a while back we had a challenge with retention and suppression. And one of the things that the team decided to do was to form a club that would help the young people adhere to their treatment and also make them feel that when they come to the clinic, they feel that they are at home. So the OTZ club was one of the suggestions that was provided. And in 2020, on 18th of September, we formed an OTZ. So next slide. So from the results of the OTZ, in the beginning, in 2020, we had 147 adolescents with valid viral load tests. So these are, and out of the 147, 85% were virally suppressed, which means we had not reached the clinical cascade or the target which is 95%. So that was a challenge. So in 2021, we had 88 adolescents with viral load valid viral load result tests, of whom 88% of them were virally suppressed. So you can see that earlier we had 147, but this one we have 88. So this was in the pandemic 2021, which was COVID era. So we didn't have more young people coming to the clinic to get their viral load done. So the ones who came, 89% were virally suppressed. So in the total number of adolescents enrolled in the program that year was 30. And in 2022, we had 140 adolescents with valid viral load tests, of whom 90% were virally suppressed. As you can see in the trends, each year we keep on increasing. We moved from 85 to 89 to 90. So next slide. So as part of the results, the continued results, 129 adolescents with viral load tests, of whom 122 were virally suppressed, so which was 95% that year. So this was 2023, 95% suppression. So we reached the targets that is given by the UNAIDS, and the total number enrolled in the OTZ that year was 129. So all the adolescents in the clinic that year were enrolled into OTZ, and you can see 95% of them were virally suppressed. And from 2020, we had a loss of 6 young people who stopped their treatment. And in 2023, by the end of 2023, we only lost 2, which meant we had an improvement in retention. Next slide. And with this chart, you can see on each year, we keep on improving in either in valid VL test, viral load suppression, and enrollment into OTZ. You can see there is 85%, 89%, 90%, and 95%. So you can see that there is improvement everywhere. So next slide. So in conclusion, this OTZ, this club for young people, helped improve our suppression from 85% to 95%, and also contributed in the improvement of retention in the same clinic. So which means if everybody in the world would embrace OTZ and empower the young people to live positively. This would be such a nice thing that will help in maybe curbing and eliminating HIV to in the next generation. And with that, thank you so much.
Thank you so much, Elvis, and thank you to the rest. I can't say anything that would do justice of how amazing that presentation was and how informative. And I think it really shows what great work the CCC is doing in Nanyuki. I know we're already a bit tight on time, but are there any questions to Anne, Rachel, Elvis, or Patrick? Or any other comments? Rachel, you're muted.
Hello.
Yes.
Hi. Hello, I was saying.
Yes.
Hello.
Yeah, go on, Rachel. We can hear you now.
Yeah. So you can see the team at CCC, the great work that they are doing in trying to eliminate HIV in this globe. Mine is just to pray that any other place or hospital can just emulate that. I think it's a great thing to do. We are trying to eliminate new infections by all means in the antenatal clinic, in the young people who are born with HIV. We are trying to ensure that there is no more transmission whatsoever. So thank you to my team. Can we keep the fire burning? Thank you.
Thank you so much, Rachel. And Soita, there was another input.
Maybe just to ask about retention. I can't remember the name of the presenter who presented about retention. He talked about the 6 months and 1 year. And he talked about maybe the retention is not up to expectation. It was about 92. And if you talk of retention, these are the clans maybe who have missed in the clinic. Maybe they're just there in the community. Now, what as a team, what are you doing maybe to make that your retention is maybe at 100% or at a point?
Maybe I can hand that question over to Patrick.
Thank you for that question. Yeah, we were doing at 92% on that cohort. So I say that those were people that were enrolled 1 year back, and we usually track them on 3 months, 6 months, 1 year, 2 year, that way. So on the question that what we do, so we do home visits for those clients. So we come up with a line list of patients who has missed clinic, and we give the list to CHVs, currently known as CHPs. We have those CHPs that are based on CCC, purposely for tracing this client. Recently, we have upgraded our system to have another module we are calling Ushauri. and also Nishauri. So Nishauri, it's an application that we install in patient phone just to remind them of their clinic day at their comfort place. Then Ushauri is an application that sends text messages to the client and remind them of their clinic appointments. Nevertheless, we also call them after missing the appointment. We call them every evening upon missing the appointment. Thank you.
Thank you so much, Patrick. I think we're going to have to wrap up, unfortunately, but thank you again for all of the speakers. I was very much enjoying the session, and I think everyone else did as well. So thank you. I really appreciate your time and appreciate all the hard work. Chris just put the feedback link in the chat. If you could kindly fill that out, and then a certificate of attendance will be distributed to you. Our next talk will be on the 8th of January. I'll also post the Spotlight newsletter that is on HIV this month in our WhatsApp group. So again, thank you so much. Everyone have a nice evening.
So, Charlene.
Yes.
So, actually forgot to ask this question to Dr. Burgess. But we should pass this question to her. But I would, for this this meeting right here, I wanted to actually know what is the difference between what is the standard package of care that you give to the young people in the UK. But unfortunately, I cannot see her in the chat right now.
Yeah.
So
She unfortunately had to run off at 5:15, but I can certainly pass that message on to her for you, Elvis, and get back in touch with you. Not sure if anyone else is in the meeting that is happy to answer that question, but I'll contact her, Elvis.
Okay, thank you.
I'm going to go ahead and close the meeting in about 30 seconds. So hop on the feedback link. Okay. Right. Thanks, everyone.